We have started live streaming.
So we'll start the session in exactly 2 minutes from now.
Yeah. Sure, sir. हेलो नहीं
Good morning to everyone in the United States and good evening to everyone from India. Today is a historical day. It marks the beginning of a journey of collaboration between the American Society of Anesthesiologists and the Indian Society of Anesthesiology. At this point, we would like to thank the immediate past president of ASA, Dr. Donald E. Arnold, for signing the MOU with Indian Society of Anesthesia. And we thank the entire leadership of ASA, the CEO, and Sarah Braun, who coordinated to make this a possibility. We consider it a great privilege that we have the president of the American Society of Anesthesiologists, Dr. Patrick Yam, with us today. And I'm very happy to share, when he took over as the president of the ASA, Dr. Donald E. Arnold, the immediate past president, when he introduced Dr. Patrick Yam, he said, ASA is in excellent hands with Dr. Yam at the helm. His expertise and leadership skills are a great asset to ASA, the specialty and the broader healthcare community. Given the numerous challenges and changes that we currently face in medicine, Dr. Gam would be the right person to take this forward. And he has been passionate in supporting the next generation of anesthesiologists. And this is truly an inspiration for the young residents and early care physicians. So we are so fortunate that Patrick Gam was with us this evening for Indians and for morning for all those in America. May I request Dr. Pat to give the introductory remarks.
Thank you, Dr. Bala. Hello, everyone, and greetings from the United States. On behalf of the American Society of Anesthesiologists, it is my great pleasure to welcome you to our first webinar in partnership with the Indian Society of Anesthesiologists. We are truly excited about this collaboration between two of the largest anesthesia societies in the world. Now, our organizations share several common challenges: ensuring patient safety, supporting physician wellness, and cultivating leadership. Through joint initiatives like this webinar, we strengthen our ability to exchange knowledge, develop innovative solutions across international borders, and amplify the voice of anesthesiology globally. For decades, our specialty has stood at the forefront of medical innovation, just as our two nations have led in advancing science and technology. Today's program Artificial Intelligence and Big Data in Anesthesiology, Revolution or Risk, reflects our commitment to exploring how emerging technologies will shape the future of anesthesiology and our profession. I look forward to informative and inspiring presentations from our distinguished speakers, and I would also like to extend my sincere gratitude to everyone whose dedication has made this event possible. Dr. Naveen Malhotra, ISA President, Dr. Bala, ISA Academic Chair, and our speakers, Dr. Murali Tondabadi and Dr. Japang Huang. Thank you all for joining us today.
Thank you so much, Dr. Pat, for giving your introductory remarks. And we truly share your common vision of working together, growing together, understanding together, and in making sure that this learning and experiences make the patient safety as the center point. Thank you so much for joining us today. Next, I have great pleasure in introducing the current president of Indian Society of Anesthesiologists, Professor Dr. Naveen Malhotra, who took over the reins of the presidentship about a month ago. And he's a chronic pain physician. That is his expertise, but he has been an anesthesiologist who has been working on several impactful things, including retrograde intubations. That's our first thing which I learned from Dr. Naveen Malhotra. He's keen to propagate patient safety in this country, and India needs several measures to make clinical excellence available irrespective of the geography of the country. And that's the aim. And I request Professor Dr. Naveen Malhotra, the current president of Indian Society of Anesthesiologists, to give his introductory remarks.
Thank you, Dr. Bala Venkat Subramaniam, the academic chair and immediate past president of Indian Society of Anesthesiologists. Wish you all a very happy New Year 2026. It is a joyous and momentous occasion that we are starting the new year by this historic collaboration between American Society of Anesthesiologists and Indian Society of Anesthesiologists. Both the associations are numerically very large, around 60,000 members of ASA and around 50,000 members of ISA, and ISA now the fourth largest society in terms of membership in WFSA also. The MOU was signed on 16th February 2025, and now we are meeting virtually for our first webinar. And I'm sure this is just a beginning, and in the year 2026, we will be working together on more collaborations, including, if possible, offline meetings also. Both the associations are working on a common platform of promoting academics, clinics, research, and member fellowship programs. I'm very sure that this collaboration will be fruitful ultimately to the patients, because first we are doctors, then we are presidents and secretaries. We will work together to ensure that each and every anesthesiologist is competent, committed, and full of compassion. And I'm happy to share with you that I'm also a private practitioner now after working in government sector, and my areas of focus this year is on YPL. The youth, the young anesthesiologists were the future of the country. Private practitioners, pain medicine, because I myself is a chronic pain physician, and the lady anesthesiologists. I'm sure that together we will achieve these aims, and I look forward to more such collaborations. It's a pleasure to welcome Dr. Patrick Guillaume, the president of American Society of Anesthesiologists, and I'm very sure that we'll have him in India later in this year for our annual conference. And I also thank Dr. Japang Huang, the speaker for today, along with our own Dr. Muralidhar Tandovi. And I place on record the efforts done by Dr. Bala Venkat and Dr. Bajwa, who worked in the last year along with the American Society of Anesthesiologists leadership to make this MOU happen. And I'm sure it will be a historic moment not only today, but throughout the year and the coming years. May this relationship foster and prosper in coming years. Thank you very much and welcome all to this joint webinar.
Thank you so much, President Dr. Naveen Malhotra. And I completely share your sentiments and convey my sincere gratitude to the immediate past secretary, Professor Sukhminderjit Singh Bajwa, who was the one who was instrumental in signing the MOU between ISA and ASA. Thank you, Dr. Bajwa, and welcome to this meeting. Now, I request the president of ASA, Dr. Patrick Yam, to introduce the speaker from United States, who is going to speak on behalf of ASA in this first webinar. Over to Dr. Patrick Yam.
Thank you. It is my pleasure now to introduce you to Dr. Japang Huang. Dr. Huang is a tenured professor and vice chair of anesthesiology and perioperative medicine at the University of Louisville in Louisville, Kentucky, USA. He leads clinical and translational research at the University of Louisville and U of L Health as Chief Scientific Officer for U of L Health and Associate Dean for Clinical Research at the School of Medicine, University of Louisville. Dr. Huang also serves as Deputy Director of the Louisville Clinical and Translational Research Center, funded by the National Institute of General Medical Sciences. He has received over $30 million research funding and has published over 180 peer-reviewed articles in highly influential journals. Dr. Huang is an internationally recognized expert on clinical outcome research, echocardiography, infection control, innovative COVID-19 research, and artificial intelligence in perioperative medicine. Dr. Huang currently serves as editor of the British Journal of Anesthesia, director and full examiner of the American Board of Anesthesiology, director of the American Society of Anesthesiologists, chair of ASA's Committee on Innovation, director for the Anesthesia Quality Institute, president-elect of the Society for the Advancement of Transplant Anesthesia, and president of the Kentucky Medical Association. It is my great pleasure to welcome Dr. Japang Huang.
Thank you, Dr. Kim, and thank you, ASA. Thank you, Sarah. And I'm really honored to be able to present here today. I want to thank all the leadership from Indian Society of Anesthesiology. I'm going to share my screen. Please let me know if you can see the screen well.
Yeah, it's seen well.
Thank you. Well, it's a great honor to be able to present. My topic is unlocking the potential, AI and big data in anesthesiology. What are the opportunities and current applications? And myself and Dr. Murali will talk two different parts of this presentation. I'm going to focus on the potential first. So those are my disclosures. So I have three learning objectives for this talk. One is really to understand the evolving landscape of AI in preventive medicine and critical care medicine, recognize the unique roles and responsibilities of anesthesiologists in integrating AI in clinical practice, and also identify practical strategy to prepare for the AI-driven future of anesthesiology. So why do we need AI in anesthesiology? The reason because our patient, when they go through the healthcare system for a preoperative stage until they go home, they all involve a lot of data, a lot of monitoring, a lot of communication, a lot of care pathways, and all those can be helped by AI. And when we look at the data that we deal with every day, and a lot of data we deal with are complex, and some of those are structures, some are unstructured data, and from multiple sources. You cannot find all the data at one place. And we have the data from the electronic medical record, the data from the state, from the government, on the population health record. We have the lab system, we have the radiology, CTs, MRIs, X-rays. We have the monitoring devices, your blood pressure, your arterial line, your central venous pressure, your pulmonary arterial pressure, and now these wearables. A lot of our patients have wearables. They have an iWatch, they wear it at home, and their data are being sent to somewhere. Who are looking at this data? And please realize those data are very complex and they're very large volume. And how to deal with those are not easy and cannot be handled very well by the anesthesiologist or by humans. We also have other data. Our data from pharmacy, our data from insurance company, from the billing, claim data, the quality reporting system, the education system, the OR management system, and also research programs. A lot of research programs like genomics data are also available to use in clinical practice nowadays. How to put all the data together cannot be handled over well by human. So this is the cardiac OR. I'm cardiac and transplant anesthesiologist. If you look at this, you are very familiar with this. We have a lot of data. I call this as information overload. You have to look at the surgical field. You have a look at the echo. You have a look at the pumps. You have a look at the monitors, your blood pressure, your pulmonary artery pressure, your central venous pressure. Then you have to look at the ventilators. What's your tidal volume? What's your FiO2? And there's some additional monitors to monitor the oxygen level of the brain, to monitor additional cardiac output and mixed venous oxygenation. To put all those together, can we do it as a human? Yes, we can. As human, as anesthesiologists, we're trying to do those. However, our brain will prioritize. We will not be able to pay attention to all those information. We only prioritize the information that we think are important. So that creates an issue. How can we get all the data in a usable format for the anesthesiologist in real time? And that's where AI comes in. So if you look at the last decade, there were really three major technologies. We call this arc of technology over the last 10 years. One's wearables and Internet of Medical Things. What this does is it creates a whole lot of data for us. In addition to the macro data we have something called big data. And simply put, just a whole lot of data that cannot be comprehended very easily by human. Now with AI. So what the AI will be able to do is really to help us analyze the data and provide clinical decision support to the physicians, and then we can take care of the patient better. Every time when we talk about AI, machine learning, there are a lot of misnomers. Like, what is AI? What is machine learning? Are they the same? So AI is a big bubble. So machine learning is a part of AI. And in machine learning, we also have something called deep learning. We're going to talk about this a little bit. And another thing that you will hear about is called natural language processing. The large language model is one example. So natural language processing and machine learning, they overlap, and also they overlap with deep learning too. So I'm going to talk about what are the different types of AIs. The first one, probably the easiest one for us to understand, is really supervised learning models, such as things that we commonly use, logistic regression, decision trees. So what they do, they use label data. Like I already know what the data means, such as blood pressure 190, that's hypertension. So we already label those data so the models can learn from those. Sometimes the data is too much or is too complex for human to make labels to that. And then we use models such as unsupervised models. And examples are PCA analysis, principal component analysis, k-means. Those will draw inferences from the patterns and associations from the data by themselves. A new machine learning model is really becoming a major force in the last few years in healthcare. It's called reinforcement learning. So what that means is the model will learn from the action of itself and in the environment through reward and penalty signals. So if the model performs well, it will reward itself. So it will perform similar calculations over time. And then deep learning is really, it will use multi-layers of connected neural network, just like the human brain. So this will allow us to progressively extract higher level features from the raw data. And multi-layers of the networks are connected backward and forward. So what this will do is really calculate the weights and the biases to complete the identification or prediction that we have. Natural language processing is really for us, for the model to understand the human language. So I'm going to give you some examples regarding those different models. The first one is supervised machine learning model. So this study analyzed 13,000 patients going through surgery, and about 90% of the patients had a hypotension, low blood pressure after anesthesia induction. So what they did, they got this data set. They divided the data set into 70-30. 70% of the data will be used for training model. Then they train all kinds of machine learning models, identify the best models, and then fine-tune this model, and then use this fine-tuned model to do the testing in the testing data set. So what they found is they do pretty well. And one model, gradient boosting model, was able to achieve the positive predictive value of 96%. And sometimes the data is just too much, too complex for human to label those. In that case, we use unsupervised learning model. So in this case, as you know, every medication, they got labeling sections by FDA in the United States. There are three major sections: box warning, warnings and precautions, and adverse reaction. So they use this AI model. They calculate the possibility of every topic given to a certain drug. Then they assign each drug to a single topic. What they were able to do, based on the topic assigned to the drug, they were able to identify adverse events that has not been identified before. And they are able to identify the potential therapeutic effects that has not been identified before. And I'll talk about reinforcement learning a little bit. I'll give you an example. So what that means, this algorithm is asked to do a certain task. And we want this model to learn from its subsequent mistakes and successes. One example that we deal with every day. Let's say we get a patient, we monitor the base value, the bispectral index value, and also their blood pressure. Our goal is really to maintain the base and the blood pressure in a certain value. As we all know, if we give too much propofol, the base will be lower, but your blood pressure will be lower too. So in this case, this model will be able to learn the best policy of this algorithm, and then it will assess and give a decision, see how much propofol I want to infuse. Then based on the base value and mean blood pressure, it will refine the model by itself. As you can see here, they actually do a pretty good job. They were able to maintain the base value and also the mean blood pressure in the range pretty well. And sometimes, as a physician, we all know some of those data are just too complex to develop mathematical models. Blood pressure 92 versus 95, it really does not make a difference for me to make a decision for the care of the patient. So they use something called fuzzy logic, meaning that we don't look at the exact value. Instead, we give them a gross classification, such as heart rate. I define as mild bradycardia, mild tachycardia, or moderate tachycardia or bradycardia. For the blood pressure, I divide it into mild, moderate, to severe. And what they found is they were able to develop a diagnostic alarm system using this fuzzy logic, and they were able to develop a system that can pretty accurately diagnose hypovolemia with a substantial degree of accuracy. And when we make a decision in clinical practice, we use something called decision tree, right? So we make a decision and say, if A happens, my choices are B or C. If C is the choice, then I'm going to go to D and E. So this is the basis behind the decision tree making process for AI models. So this study, what they demonstrated is you can use this model really to predict the patient control analgesia pretty accurately for how much they're going to use and do readjustment. And we talk about the neural networks and deep learning. So what they do is they analyze all the available features within the training set. In this example, we have the EEG, the power, the entropy, the mean blood pressure, heart rate variation, and we really don't know the relationships among all of those. So this neural network will be able to learn all the interrelationship and give me output. And the output is this patient awake or this person asleep. So deep learning is potentially a very powerful tool when there are just too much data and too complex relationship that is very difficult for human to label by hands. And we talk about natural language processing. So simply put, it's an AI model that try to understand the human phrases, sentences, and paragraphs. And as a physician, one of the most important things that we contribute is really to do documentation. Not only we put the lab data, the actual findings, we also put the thoughts behind this, why we get this decision, why we make that justification. And so there are multiple studies show, actually, if you use natural language processing, you do a much better job to identify post-op complications. And this study showed you can have a higher sensitivity and low, but at the same time, with a lower specificity when you compare to self-reporting system for complications. And one of the other things that we use more and more in the US and in India is really ultrasound. right? We use loud ultrasound. We use that for line placement. We use that for echo. We use that to assess the lung volume. We use that to assess the gastric volume too. And over the last 10 years, one of the major development has been computer vision. So really the model will be able to understand the images, the videos, and other visual data. So this will give you an example of the epidural space. If you look at here, yellow means the accurate determination by the AI model and also by the identification of the epidural space. You can see they perform really well. If you look at the 3D data set, their accuracy for the lateral resolution can be within 1 millimeter. That's more than adequate for clinical use. And let's look at the growth of AI in research. So over the last, really starting about 2020 with COVID hits, and the AI has grown significantly in publication. And in 2025, we almost hit about 100 publications for AI in anesthesiology. So those are the top 5 most cited AI and perioperative medicine publications. As you can see, starting from 2018, it's a supervised machine learning post-induction hypertension prediction, post-op complication prediction, machine learning, and also the smart alarms in OR and ICU. So when you do those AI models, one of the most important things is you have to have good data set that promotes a great deal of collaboration at different countries and across countries. So China, India, United States, there has been a lot of collaboration. And also you can see a lot of collaboration by different authors. So the topic of AI in anesthesia also changed over time. In 2021, we talked about hemodynamic monitoring, blood pressure. Over time, fast forward to 2023 to 2025, we're talking about machine learning, AI, prediction, and risk prediction. So I'm going to give you some example of clinical application of AI in anesthesiology. And when we think about AI in anesthesiology, there are really 2 core functions. The first one is prediction, right? We have so much data on the patient. We want to know what's the complication that can happen with that patient. The second one is control. And one of the things we talk about is closed loop systems. Based on the propofol infusion, the base value and the mean blood pressure value, can you control the anesthesia by itself? And when we have a patient from, with all kinds of data from the labs, from their vital signs, from their history, and we can divide the patient into high risk or low risk. If we have a low risk patient, the patient can go to conventional anesthesia with standard monitoring. If we identify a high risk patient for high risk procedures such as ASA 3, 4, and with cardiopulmonary disease or with the prior complication, we can use AI to predict the complications. Sometimes we can use that in real time in the OR, can predict, will my blood pressure go lower if I do this, and really can augment the care of this patient. To summarize, for AI in perioperative space, in pre-op, we can use the AI to drive risk stratification. Intra-op, you can do autonomous monitoring. Instead for us to look at the monitor every second, the AI will do it for you and summarize for you, and we can have a closed loop controls. For post-op, we can use AI to predict outcomes and predict the recovery of this patient. And there are multiple challenges Dr. Marati will talk about, such as the training data biases, individual disparities. And if you get a new case, the AI never saw this case before, it will not be able to do very well. And then we have issues with oversight. Who's in charge? Is that AI or the physicians? How do we share the decisions? And then certain regulations to safeguard the data. What are the ethical considerations? What are the transparent regulations that we need to consider? So we talked about the fuzzy logic just a few minutes ago. And so this study, they used 11 features from the EEG signal. Then they applied this fuzzy logic system to there, and they were able to find that their accuracy is really good. So the accuracy is 92% if you try to predict whether a patient sleep or awake with a sevoflurane. And they were able to achieve 93% accuracy if they predict this in propofol infusion. And it's always a dream of myself and many of you to see, can the AI, do we have a machine, can do automatic anesthesia delivery? So they actually developed this in 2016. So they call that Max Sleepy. So they said, well, as anesthesiologists, we have 3 goals. 1, we want the patient to sleep. so they monitor the base value. Second, I want the patient to have a plan-free, so they have the analgesia score based on the EEG. And the third one is I do not want the patient to move, so they monitor the neuromuscular blockade. So they were able to perform really well. They were able to perform at excellent or good control over 70% of the time. And only in 3% of the time, they have insufficient clinical performance of analgesia, which is really good. And I have to honestly admit that's probably better than my performance. And how about in clinical use? So one of the things that we use in the U.S. in my hospital on a daily basis, we use something called hypotension prediction index. If you look at the arterial line, the simple waveform, it contains over 3,000 individual features. If you combine those features together, you have over millions, over 2.6 million features. So based on those features, they say, I want to predict whether based on those features of this arterial line, will this patient be hypotensive 15 minutes from now, or 10 minutes, or 5 minutes from now? They were able to achieve over 92% sensitivity and specificity 5 minutes before the actual hypotensive event happens. And they did internal, external validation, and also they use this score to see whether the hypertension can be reduced. And AI can also use to predict the unplanned ICU admission. So as anesthesiologist in OR, you always wonder, will my patient need ICU afterward? Because that has a lot of implications, right? Someone have to make the planning. So we need to let the ICU team know this patient needs ICU. Sometimes they have a patient in the room, so they had to move patient around. So if we have a tool that can help us predict the early unplanned ICU admission, that will be very helpful. So based on something called transfer learning, so you learn from the data from a big data set, and they apply that to the individual patient, they actually was able to predict which patient will need ICU admission. And they actually perform much better than the physicians or the score that we currently use. And this study also very interesting and also confirmed that as a physician, so you see this one right here, these are prediction of post anesthesia care unit hypertension, and we do not do very well. If we combine the AI and the physician, we do better. However, the AI model alone does the best job. And one exciting thing about this, every time we think about AI, we all think about it as a black box. We don't know what happened. We don't know how they calculate. We don't know how they predict. In this study, they actually showed one of the features that's most important for prediction. What are in this case, procedure type, sex, medication use, the minimum blood pressure are important factors in there. And sometimes as anesthesiologists, we always wonder how long the surgery will take. The surgeon will tell you 30 minutes, and you know that's not accurate. So if you just use multi-regression model, you can see the red line perform not very well. The star is the actual time. If you use the AI model, the neural network, you actually will perform more accurately. And this is my own study. My interest is really to improve the kidney outcomes after cardiac surgery through transfer learning. So what my team will be able to do is based on the patient demographics, the urine output, serum creatinine, and other factors, we develop a policy to see what medication will you use. Should we give the patient blood transfusion? How much fluid we should use? And based on this, we'll make a recommendation to the anesthesiologist. They will take action. Then my team will monitor the state of this patient again to be able to adjust the recommendations. And what we found is one, the model is called Transformer 6 layers. So what that means, it will remember all the history, what we did to that patient. They perform much better than the recurrent neural network. So AI in anesthesiology is really developed pretty significantly. This is a very nice summary in 2025. So we have the closed loop control of anesthesia in AI, and they actually have done a randomized control trial with over 1,000 patients. They got FDA approval, but eventually they pulled out because of marketing considerations. We talk about the max sleeping, and one of the issues, this is a pilot single center study. We talk about the closed loop anesthesia depth control, also a single center randomized clinical trial. We talk about a hypertension prediction index, and that has been used commercially. We can talk about the machine learning for post-op complication prediction and also AI-guided anesthesia in low resource settings. And if you look at this, and the key benefits of AI are significant improved depth control with AI, more accurate propofol titration, faster anesthesia onset, reduced intervention burden, and low complication rate, and also in many times machine learning model outperforms manual adjustment for AKI prediction. We talk about it, use AI to understand the ultrasound. So what they do, they call something decoding and upcoding to be able to identify different structures. If you think about ultrasound, they are really black and white dots with a different intensity. AI will be able to analyze not only the dot itself, but the surrounding dots to figure out which structure is the correct structure. And one of the folks over the last 10 years really try to use AI in ultrasound to help the trainees. However, in the future, we hope this actually will be able to recognize diseases, make diagnosis, might be able to do better than the experts. And this is something my interest in echo. I do a lot of transesophageal echo and transthoracic echo. And this is a very exciting development. It's called Echo Prime. So they use AI model to analyze over 12 million videos in over 100,000 patients. They analyze 275,000 studies. So they classify the view, then they learn from the report of the echo, combine those together, use something called multiple instant learning, learn all those instances at the same time, and they call something anatomic attention to use our knowledge about the anatomy of the heart to do a better prediction. And what they were able to do is really be able to look at all the echo pictures and then select the views that's important for the left ventricle, then give you the diagnosis right away. I will not play all the video, but they can analyze the valves, LV, RV, and all those features. And they actually perform much better than other models. One of the most exciting things you realize is they actually can make diagnosis that has not been mentioned in the report. So in this case, they can predict amyloidosis and the FT elevation MI. So this is another study published in JAMA last year. So they developed something called a pan echo, so they can automatically diagnose and do the full interpretation of the echo report. So eventually, the day will come, there will be a robot anesthesiologist in the room. And this has been a reality in China. I attended a meeting in China last year. This has been developed. They're doing clinical trials. So what will be the roles for anesthesiology in this case? So we will not be the one doing direct monitoring. Our role will turn to supervision model. So the AI will take over repetitive data-driven tasks, such as tracking vital signs, adjusting anesthesia dosages. For us as anesthesiologists, we'll focus on the complex aspect of the care, requiring intuition, critical thinking, and ethical judgment. And sometimes we talk about AI is a black box. And nowadays, there has been a lot of effort to make AI explainable. So you can tell the AI to give me the reasons why you think you make this prediction and why what are the factors you think are important. And we touched briefly on the natural language processing. And what that is, it can understand human languages, the charts, and the data. And what we want them to do is really to summarize those in concise, explainable, and actionable. So the machine learning-based algorithm, they actually will be able to detect heart failure in early stages before the physician realizes the patient is heart failure, and will also allow us to discover subtle differences in surgical population and uncover the practices associated with the best and worst outcomes. And one of the things that I know that nobody likes to do is do the pre-op evaluation. If you talk to the resident, they hate it, right? The question comes, can the AI help? So this is the publication published in BGA on the ChatGPT 4.0. Unfortunately, ChatGPT is not quite there. The really does not consider meet the minimal requirements. And however, in a study published in JAMA, they found actually ChatGPT and other large language model, they were able to help with the risk prediction and prognosis diagnosis. So to summarize, for AI for the physicians, we can use AI to interact with our patients. We have something called ambient voice and dictation. So the AI will listen to my conversation with the patient, will write a note for me, risk prediction, diagnosis, to really to read the lab results and X-rays, and to really change the behavior of the patients. I talk to all my patients on smoking cessation, but not many nations. The AI can take over their job, can help the surgeon with the procedures, can prescribe medications, and can monitor the patient or do population health, and can do research and learn, and can also do education and training. When we think about AI models, when we treat it, we really should treat them as drug development. AI, just like a drug, we want to develop in different phases, from phase 1 to phase 4. And I'm going to go to my summary slide. Those will be covered by Dr. Morali. So to me, AI has the potential to impact clinical practice anesthesia, really can go from pre-op to intra-op to post-op. And we must learn and understand AI. It's really crucial for us as anesthesiologists to provide practice-based insight to help the development of AI. Thank you all very much. So this is my lab, my collaborator, and my funding agencies. Thank you.
Thank you so much, Dr. Jia Peng Hung, for giving a very lucid and elaborate presentation about the augmented intelligence and its role in the perioperative period. And your final message saying that every anesthesiologist should incorporate into his thought processes the AI to get the best benefit to the patients. Thank you so much for your splendid delivery of information regarding to AI. So I next have the great pleasure of introducing Dr. Murli Tondebavi, who would be the speaker of the day on behalf of the Indian Society of Anesthesiologists. And Dr. Murli Tondebavi Subramaya is the rare clinician who refuses to be confined by convention. He's a consultant in anesthesiology and pain management at Apollo Hospital, a corporate specialty hospital with multiple branches across this country, and he works in the city of Bangalore. He also has fellowships from the Royal College of Anaesthetists UK, and it's been a faculty of pain medicine. He serves as the Associate Dean of the College of Indian Society of Anesthesiologists, and he sits in multiple international committees, including he has been selected for the WFSA's Workforce Wellbeing Committee. But he also is very interested in other facets of other than anesthesiology. He's the author of Think Like an Anesthetist. It's not a clinical textbook, but a bridge to the public, distilling the mental models we use every day in critical situations into lessons anyone can apply to improve their lives for non-anesthesiologists. He produces and hosts not one, but 2 podcasts. The Indian Journal of Anesthesia podcast, bringing academic insights to life. And we thank Dr. Patrick Gam for being one of those who gave us excellent insights in the IJA podcast, which was released a couple of months ago. And Dr. Murli also invests time in the next podcast called The Luminary Lounge, Insights from Lives Well Lived, where he explores wisdom from remarkable careers. He's also an active blogger, and which could be seen at murlitondebavi.com. He's an amateur photographer whose lens captures what words sometimes cannot. So he has also been a part of technology, and he built a Zelsia app for anesthesiologists, and currently is involved in building an app for the Patient Safety Association of India. And speaking to us today on AI in anesthesia, Dr. Subramaya brings the perspective of someone who has already been living at the intersection of medicine, technology, and communication. I welcome Dr. Murli Tondebavi Subramaya to present his thoughts on AI. Over to Dr. Murli.
Thank you, Dr. Bala. And I would like to thank the leadership of both the American Society of Anesthesiologists, the present and the past, and also the Indian Society of Anesthesiologists for having this wonderful historic webinar. and a Happy New Year to all the viewers who have logged in from across the globe. So as Dr. Hyang was mentioning about the uses of artificial intelligence and anesthesia, I would be covering in the next 20 minutes the challenges, the safety aspects, and ethics revolving around this very fast-changing subject across the globe. So I don't have any conflict of interest for this talk. And when we question why are we having this webinar as the first webinar of the collaboration, it's because AI is rapidly reshaping the landscape of modern medicine as we know it. Anesthesia is definitely the next frontier because we are data rich, as Dr. Huang mentioned. We deal with high stakes environment, and of course we are global. And this talk, which I'm going to give, is going to cover about the safety, the ethics, and the practical challenges that we need to address today. I want to take you through a thought experiment. I don't know how many of you have seen this picture, the Back to the Future. I go back to my teenage years where I was probably enthralled by seeing Marty, the character here with Professor. But I have just got a little retake on this. So we have an anesthesiologist who's traveling with Marty on this space adventure, the time adventure. And they go to the OT, OR setup in 2035, and they see this. There is no anesthesiologist to be seen. And they say, let's go to another hospital and see, and you see an anesthesiologist looking at various screens handled by AI. And as you can see here, one screen is predicting hypertension, the other one is telling, okay, patient is going to wake up in 2 minutes. So if you look at one of the possibilities of AI, which Dr. Huang was mentioning, that he has seen one of the models working, you are going to walk probably into a fully integrated smart OT. Now, when you think about this thought experiment, the AI is titrating the anesthetic depth, the fluids, and the vasopressors. It is making real-time predictions about hypotension, hypoxia, and whether the patient needs an ICU. And of course, as our previous speaker mentioned, you're moving from becoming an active pilot in the OR environment to becoming a system supervisor. Now, the question comes, are you in control or is the algorithm in control? So with this question in mind, let's look at what we're going to explore in the next 15 to 20 minutes. We are going to look at what the future of AI holds for us with realistic trajectories. We are going to look at what is the safety issues that we have to deal with, where we have to balance the benefits against the new algorithmic risks. We have to look at the ethics component, which includes fairness, transparency, consent, and accountability, the practical challenges, and of course, how are we going to regulate this? How are we going to train our future workforce, and what is the global action needed? So why is AI coming to anesthesia? We are a data-rich environment. AI is nothing but interpreting data. So in anesthesia, we are generating continuous data, whether it is physiological parameters, whether it is data coming from the OR setup. We have a data-rich environment, which the AI loves. There is an efficiency pressure across the globe where we are required to produce or give out more output and also bring about cost reduction. And there is definitely a workforce strain which is being experienced across all the anesthesia societies. So AI has already started its journey in radiology, pathology, oncology, and it's going to come to anesthesia. And as Dr. Huang was mentioning about the emerging use cases, we can use it preoperatively, intraoperatively, predictive monitoring, postoperative for, of course, predicting pain management, delirium and triaging, and OR scheduling, case duration and staffing, documentation. And this is where we are presently. Why is it so important that we need to understand AI and what it's going to do? It's going to detect things early because it can analyze data much more better than a human. It can reduce human error by picking up things early. And of course, we can have a little bit of offloading of the routine cognitive parameters that we are already kind of getting in and do the things that are more human, like talking to patients or picking up complex cognitive tasks. But there are limitations of current evidence, and we must be cautious because the high accuracy which we are seeing with retrospective data might not transfer to the real world. So there is a gap. The patient outcomes by using AI is still in its nascent stage. We don't know whether using AI will make a difference to patient outcomes. And of course, most of the experiments, most of the data coming out are coming out from silos. They're small hospitals or hospital group setups which are actually collecting data, and we don't have nationalized or global data sets yet. So we must acknowledge this current evidence gap before we move ahead. And also it is going to pose new safety risks. So let's talk about automation bias. Now, Tesla cars, to take for example, are driving by themselves. Now, if your anesthetic machine drives by itself and you're just sitting there, you're going to be over-reliant on AI. You're going to ignore the clinical intuition that you have developed over decades. It cannot be generalized to all populations because a model developed on one population is going to drift when applied to new populations. So it's not going to work. It's going to have silent errors. There is a bug in this algorithm. We are going to be dependent on this, and suddenly it might go unnoticed. Data corruption might occur. And of course, the real trouble is this. The anesthetist already nowadays is hooked onto a mobile phone in many places. And now with the AI coming in, you might see this. Anesthetist, despite his coffee, might be dozing. And of course, you have a skill de-skilling happening. You might actually not be able to think, which is happening across right now with use of large language models. Anesthetist might not be able to deal with a critical situation because now he's highly dependable on AI. So these are the new safety risks that we should kind of think about. Then most importantly, what I'm going to discuss in the 5 minutes coming from here is ethical domains, which have been established across all specialties which are using AI. The first thing being justice and fairness. The second is transparency, human autonomy, consent and privacy, and of course, lastly, most importantly, accountability. So let's take one by one and see what is there in this for us as anesthetists. Now, justice and fairness. Now, AI learns from historical data. As Dr. Huang was mentioning, we are feeding data into it. So it can freeze past inequities. So the data which has been trained on, say, let's take from 24, it freezes the data from 2024 or 2023. It underrepresents certain ethnicities, BMIs, or comorbidities. So a data set trained on a healthy 25 to 30-year-old Caucasian male might not be applicable to a 45-year-old elsewhere in the world. There is risk of systemic undertreatment of marginalized groups. So in low-income or middle-income countries, if the data sets have not been used, then you have probably a systematic undertreatment of these patients. Then, of course, the global gap, as I was mentioning, high-income countries, tools are built there, might not work in low or middle-income countries. So the fairness in these models must be an active design requirement and not an assumption. So this is the first thing that we need to address. Second, as Dr. Huang was mentioning, the black box. Now, what is a black box? Black box is something wherein we don't know how it works. How much ever light you throw on it, you can't know how it is actually working inside. To give you an example, many of you might have been through an MRI or have subjected patients to an MRI. How many of you know how an MRI works? But if you were to read up, you can know how an MRI works, but that is not the case with AI. AI, even the best of engineers who design it, do not know how it works. It's not just a tool, it's now an agent. So the transparency and the black box is going to be a very big issue going forward. So this is called the opacity problem, where the opaque models prevent clinicians from verifying the AI logic. Why is it making a decision like this? So clinicians require an explainable AI to understand why it has taken a decision, whether it is increasing propofol for a reason, noradrenaline for a reason. I need to know why it is doing that. And there needs to be uncertainty indicators, that is clear indicators for a model uncertainty or confidence. So I need to know that it's not going to work at a blood pressure of 50 or 40 so that I know that I need to take over. So we need to have safe overrides. We need to have the transparency in such a way that we can override the AI suggestions. And this is going to build trust. The clinician will build trust with the system because now he can verify that it's not just a black box concept. And this study, which was done in Germany with regards to radiologists who are already using AI, said that Healthcare budget is large but limited, one of the physicians said. So let's not spend too much on AI right now because we need to spend on patients. Another physician said, relying 100% on AI would be problematic. And the other physician said, I bring in experiential knowledge. Why should I think about using AI? And another physician said, training is crucial to understand what we are actually doing with AI. We need to know why. Why are we using this? And there is another physician who said, biases, again, data sets can carry over into AI algorithms. And this is something we should address very early in development. But there was one physician who said, as I mentioned earlier, MRI works. I don't need to know how the MRI works. If it is good, congratulations, I'm going to use it. So these were the thoughts of physicians who are already using AI in radiology. The other thing which we need to address is the ubiquitous use of the large language models. And what I'm showing you here are the frontier models, the ChatGPT, Claude, Gemini, and Grok, which most of you might be using it on a day-to-day basis. Now, this can be a strength when you're going to use it as a pre-op refresher, to check drug interactions, create rapid summaries, also have patient draft leaflets and checklists, but it also has a risk that it can hallucinate because it just wants to give you an answer. It can be using outdated data, therefore trained on different models. And of course, privacy. If you're going to upload a patient detail on it and you're leaking the patient data, that's a very big risk. So LLMs assist in thinking, but it cannot replace your clinical judgment. So this is something that I want you to take on. Next, coming to another big issue, which is consent, privacy, and big data. We are dealing with high value asset, and this asset is perioperative data. We are using perioperative data to train the AI. There are consent gaps. You are taking a consent from the patient to perform surgery, to give anesthesia, but you're not taking the consent to use that data for a large scale data reuse to train AI models. And even if you de-identify the patient, it is not a guarantee of total anonymity. So this is something that we need to keep in mind. And now the new thing that's coming up is these models can create synthetic data. On the synthetic data, we can do research. So this is a new issue about how we are going to digitally protect our patients. How are you protecting a digital patient? That is a patient whose synthetic data is produced. So next comes another big issue when it comes to ethics, that is accountability. Right now we know if something goes wrong on the table, the anesthesiologist is clearly accountable. Now there's no question about it. But in the future, who is responsible? Is it the vendor who supplied the machine? Is it the hospital which actually bought the machine and commissioned it? Is it the AI agent who took the decision, or is it the clinician who was sitting there watching this AI agent taking the decision? So this is called the responsibility gap. That is, if everyone is responsible, no one is. So we need to address this, that human accountability must be made mandatory, and new legal frameworks must be updated so that AI is included in it and we understand what is happening. Now, I could take you back a little bit, 20, 30 years ago, and this was a seminal moment when it came to patient safety and medical errors. So this was published by the Institute of Medicine, To Err is Human. Now, going forward, we need policy and regulation of similar kind. We need to move from just moving fast to moving safely. So the same Institute of Medicine, now called the National Academy of Medicine, has come out with a code that AI must be safe, reliable, secure, and equitable. The American Medical Association has come out with a policy where they are mentioning that AI is called augmented intelligence. It's not artificial intelligence. It has to augment your decisions. The EU AI Act is one of the biggest acts which has come out for AI, and it classifies medical AI as a high risk, and there should be strict oversight. There should be rigorous documentation and post-market monitoring of this, and standards should be set by anesthesia societies such as ISA, ASA, and of course, the big societies across Europe, and they must lead in setting specialty standards. So this is actually the document from NAM, which you can all access. This is online, and this is the AMA statement, which also talks about. But I would like you to spend a little bit more time on this if you're interested, which is called the EU Artificial Intelligence Act. Now, this is a huge document. It is, I think, 2 to 3 lakh word document. And this is telling that risk-based regulation like medical devices should come into AI. There should be mandatory safety, data quality, and human oversight. Transparency and logging for clinical decisions is mandatory. Hospitals should be responsible for governance and monitoring. And why this is important is EU forms the second largest consumer for electronic equipment, which is regarding healthcare. It's the second largest healthcare market, second to America, with close to around $3.5 trillion spent every year. And all the companies which will be compliant with the EU Act will have to come out with standards which are very safe. So that is the reason this act is extremely important. EIA, as Dr. Hang has mentioned, is a research tool where we can use it for data mining, research acceleration, and the key risks here is that spurious patterns in big data can come into the final results. So for this, the 2024 Declaration of Helsinki, which is the main thing which looks at ethics in research, explicitly covers AI and big data research. They are talking about, again, focus on transparency, justice, and fair benefit sharing. So you can read about all this online. Now, how do we go about? Now, we have a lot of head of departments here, professors, and a lot of heads of societies. So when it comes to an institutional governance, you need to ask the first question, that is, does it work in our specific OR flow? Is the data pipeline secure and robust? Is there a clear definition of human oversight and kill switch roles? Kill switch is when the human can actually switch off the AI and take over. Is there a mandatory reporting system for AI-related near misses, not the human near misses, the AI-related near misses? Are we going to do regular audits for bias, data drift, and clinical utility? This, again, is a wonderful document looking at how a developer should be responsible, a deployer should be responsible, and a physician should be responsible for planning and development and implementation. This is, again, a wonderful document which I would like you to go through if you are in the policy making for institution, because it provides an excellent checklist as to how you should incorporate AI into your hospital system. So the 6 questions as an anesthetist you should ask before you trust the screen, which has got AI, is it validated in patients or contexts like mine? Is it trained on data elsewhere in the world? And does it work in my patients? Is there a benefit? Or is it going to show an improving outcome? It might show that hypotension might occur after 5 minutes, but is it going to improve the outcome? So this is something very important. Does it integrate safely into my current workflow? Am I able to use it, or I need to kind of change my workflow? Do I understand the why behind the prompt? Is it transparent enough that I understand why it's making this decision? Has it been checked for bias in my population? And of course, who is responsible if I follow this advice, right? If it tells that it's going to cause hypotension and I follow and I do something, am I responsible or is the AI responsible? So you need to be extremely careful about these questions. Coming to training, which again, Dr. Hang mentioned, it's extremely important. When we were trainees, we were trained how to use the anesthesia machine, check the machine, but now things are changing. We should learn how to supervise the systems from just doing. So we need to be able to supervise intelligent systems working next to us. We need to be literate in AI. We need to learn how AI works. We need to be able to detect when an algorithm is failing at the bedside. We need to have manual skills if the autopilot fails. So it's like a Tesla car, right? If the Tesla car suddenly decides, I'm not going to drive you, you need to be able to drive the car. And finally, you have to know how to integrate AI ethics into residency and CME curriculum. And in this context, there's a wonderful initiative taken by the National Board of Examinations in India, wherein this course was introduced recently. It's artificial intelligence in medical education. So I urge all the listeners and viewers in India to take up this course. It is free. You just need to be a medical practitioner and you need to register. It's a AI literacy course which has got 4 modules, and the trainers are all eminent faculty from AI and the software industry. Now, coming to patients, we've been talking about doctors, why we need to use AI, why anesthetists, but does the patient want AI, or does he want an empathetic anesthesiologist at the end of the day? This is a question that we need to ask patients. Are patients ready for AI? And the second important biggest question that we need to ask, are these global data centers which are using AI warming the planet up? We have stopped using nitrous oxide. We have stopped using desflurane. But by using AI, are we harming the planet? So this is a sustainability question that we need to ask, apart from all the other questions that we've been asking. So coming back to these 2035 operating room. The question is it safer or just shinier? Now, I would like you to kind of revisit probably 80 to 100 years ago when the Manhattan Project was being planned. We were trying to untap the atomic power. We were trying to kind of get into the nucleus of the atom and see how we can harness the power to create this. Now, some good humans intervened in between and said, no, we need to sign treaties. We need to come up with something where we are not going to destroy ourselves, but we are going to use the same to actually create power, create good things out of this entire science that's coming out. So we are at crossroads now where we need to question, and as stakeholders who are going to be using it, we need to probably play a very key role in shaping this next future. So the goal should be that we should look at AI, which is augmented intelligence in anesthesiology, as a co-pilot that amplifies judgment and not as an autopilot that erodes it. So the future we choose is that AI should be an inevitable partner because it is going to come to us. We need to be able to design the safety and ethics, and it should not be an afterthought. We need to address this bias, transparency, and accountability because they are going to be the central pillars. And our role from moving from a passive user to critical co-designer is very key. So what can we start doing today? So I would like to summarize by saying that please incorporate AI literacy into daily teaching and residency, and do train yourself in AI. Use structured checklist if you're going to be adopting new technology. Ensure anesthesiologists, that is yourselves, join hospital AI ethics committees. This is going to come up. This is going to be the future. So join early on so that you can make decisions. Discuss AI-related incidents in and quality improvement meetings. Push for joint standards. So as societies right now, we are having a joint webinar. So I feel that we should all come together and have joint standards for perioperative AI. And success of all this is having a safer, fairer, and more humane anesthesia for the entire world. And finally, I would like you to kind of go through this quote that the reasonable man adapts himself to the world. The unreasonable one persists to adapt the world to himself. And therefore, all progress depends on the unreasonable man. If you're watching this on your smartphone, you have to thank Steve Jobs. You have to thank all the innumerable people who have actually contributed to this technological progress. And this time, for the first time, the Time magazine doesn't have a person on its front page. It is actually the architects of AI who are actually on the front page. And this is something that we need to keep in mind, but also work together to create a safe, equitable future for our future generation. So I would like to again thank the leadership of today, of the past, of Indian Society of Anesthesiologists and American Society of Anesthesiologists for taking this wonderful collaborative step in bringing us together and bringing the next generation of anesthesiologists into a new forum. Thank you very much, and thanks to Dr. Bala Venkat sir for introducing me. Thank you.
Thank you so much, Dr. Murli, for that very elaborate presentation and also giving real insights into what are the challenges. And I think every anesthesiologist, it would be an exciting journey to incorporate into a thought process and the help of AI. In the interest of time, I think we will take just one question. And that question is to Dr. Jiapeng Huang. Where and how can we get already validated models on which federal learning or further validation with regional data can be performed?
Sure. Thank you for the question. And I think this is something that actually is definitely being active research nowadays. So we have a lot of, every time if you think about new medications, right, you have to go do a randomized clinical trial. You have different phases of clinical trial. But for the AI, the clinical research on AI is very few. So meaning there's some initial retrospective study, but there's really not many studies to study whether that AI model will make a difference on the clinical outcomes. And one of the reasons because of the cost. It will cost millions of dollars to do the studies, and most AI companies are small startup companies. So that's something that we try to push. We need to generate evidence for AI models. although it works on there, but does that actually make a difference in clinical outcomes? I think that will be the future for AI study, and we just not quite there yet. So I think that's one of the other limitation that Dr. Marati mentioned is it gotta be evidence-based. Right now, the evidence is not quite there to support the really the full scale use of those AI models.
So thank you so much, Dr. Wang. And one question to Dr. Murli. Is the whole exercise cost effective and how it can be incorporated in a residency program? And your thoughts?
Sir, as I mentioned, AI is coming. We cannot avoid it. And we need to train the future workforce in using AI and using it in the right way. I don't think we need to question the cost effectiveness of AI training right now because it is invaluable. As anesthesiologists, we are dealing with data and we need to know how to use this data because AI is going to eat this data. And the one thing which I failed to mention is AI is not like a tool. An atomic bomb was a tool which the human could say, I'm going to drop it or I'm not going to drop it. Whereas AI is going to be an agent. It is going to have its own thinking. So unless we train this AI in the right way, as Dr. Hang was mentioning, we are going to have agents who will not be able to decide the right way. So as stakeholders, as people using it, we have to start learning, we have to start using. And the NB program, which has been started, is, I think, a very futuristic thinking one because we need to train all doctors in India how to use AI very well, not just using ChatGPT or Claude, but how to understand AI, how to understand natural language processing, deep learning, and machine learning. So this is very important.
Thank you so much, Dr. Murli. And I couldn't avoid this last question, and this is to Dr. Pat himself. Is the ASA mandating taking patient consent when the clinician uses AI?
That's a good question. So the way our consent works, it's largely from institution to institution, but there is not yet widespread requirements to talk about the use of AI.
Thank you so much. So before we go for the conclusion and the vote of thanks, I have great pleasure in introducing the Honorary Secretary of the Indian Society of Anesthesiologists, Dr. Rajiv Gupta, to share a moment of his thoughts with us.
Respected leaders of the American Society of Anesthesiologists, Dr. Patrick Jia, President ASA, Dr. Jiepeng Huang, Chair Academic Committee of Innovation, Sarah Brown, esteemed office bearers of Indian Society of Anesthesiologists, Dr. Naveen Malhotra, President ISA National, Dr. J. Bala Venkat, Academic Chair, and Dr. Sukhbinderjeet Singh Bajwa, Past Secretary, ISA National. Distinguished faculty, researchers, and dear colleagues, wishing all a very happy, healthy New Year and a very warm welcome from ISA headquarters. It's a matter of great pride and privilege to welcome you all to this historic first ever collaborative academic meeting between ASA and ISA. Today's interaction represents much more than a virtual meeting. It signifies the beginning of a strategic academic partnership aimed at advancing anesthesiology through innovation, research, and global knowledge exchange. Anesthesiology stands at a threshold of transformative era. Artificial intelligence and big data are rapidly reshaping how we assess risk, deliver anesthesia, monitor patients, and predict outcomes, and improve perioperative safety. From AI-driven decision support systems and predictive analytics for perioperative complications to machine learning models that optimize drug dosing and resource utilization, the future of our specialty is being driven today. In this context, collaboration like this are especially meaningful. India offers an unparalleled advantage in terms of large patient volume, clinical diversity, and real-world data, while the ASA brings strong frameworks for research methodology, validation, regulatory rigor, and patient safety standards. When big data meets structured research and AI expertise, the possibilities for meaningful practice and evidence are immense. This collaborative provide a unique platform for joint research initiatives in AI, machine learning, and perioperative analytics. Ethical and responsible use of big data in anesthesiology, development and validation of predictive model relevant across diverse populations, training and mentorship in young anesthesiologists in research and data science, sharing global best practices in technology-driven perioperative care. At the same time, we must remember that technology should augment, not replace clinical judgment. As anesthesiologists, our responsibility is to ensure that AI remains patient-centric, ethical, transparent, and evidence-based. Forums such as this allows us to collectively define those boundaries and standards. On behalf of Indian Society of Anesthesiologists, I extend our sincere gratitude to the leadership of American Society of Anesthesiologists for their vision, trust, and commitment to collaborative academic growth. I also thank all the distinguished faculty and participants who have joined us today to share their expertise. Let this meeting be first step in the sustained academic journey where ISA and ASA work together to shape the future of anesthesiology, leveraging artificial intelligence, big data, and human expertise to improve patient outcomes globally. I wish the meeting a great success and look forward to many more such collaborations in the years to come. Thank you.
Thank you so much, Dr. Rajiv Gupta. May I request President of ASA to share his summary and closing remarks, which would be followed by vote of thanks by Dr. Suminderjit Singh Bajwa. Over to Dr. Pat.
Thank you, Dr. Bala. On behalf of the American Society of Anesthesiologists, we want to thank the ISA and also our participants for joining today's historic webinar. And I would like to thank again and extend my appreciation to everyone whose dedication has made this event possible. Dr. Naveen Malhotra, ISA President, Dr. Bala, ISA Academic Chair, and our speakers, Dr. Murali Thandabavi and Dr. Japang Huang. These were outstanding presentations. We are excited about future webinars with the ASA and appreciate you joining us today. Thank you.
Thank you so much, Dr. Pat. And we are truly delighted in this new journey. And we look forward to having several such journeys which would make huge impact in our patient population. Thank you so much. And now may I request Professor Dr. Sukhminderjit Singh Bajwa, the immediate past secretary and the one who was instrumental in signing the MOU between ASA and ISA, to propose the vote of thanks. Dr. Bajwa, please.
Thank you, Bala sir. I think what we conceived 1 year back, today it has borne the fruits, and it's been evident by the comments as well as all the feedbacks given by our audience. And thanks to, first of all, ASA, the immediate past president, Dr. Donald and Dr. Patrick, and our speaker, Japang Hong, who are being our guests today, and all our national leadership and our ISA members who have been instrumental in making this program a huge success. And foremost, the talks by both the speakers, they were so well conceived, and especially in the question raised by Dr. Murli, they're very relevant to the present day scenario, because we have been using AI for a long time, but now it has suddenly taken a monstrous shape now. From here to go forward, how to go forward. And it's very much needed to develop filters. We are in that stage where we have to put some filters, which part to adopt, which part not to adopt, because it's a matter of the patient safety going forward here. Not just patient safety, it's our own personal standards, the clinical acumen, it will be tested with the AI going forward. Because the data, we are talking so much about the data, accumulation of the data, large volume of patients, and see, this is just akin to the clinical significance and statistical significance. You have to choose one over the other in interpretation of the AI going forward, so that to adopt in a holistic manner and how to use it, particularly in the patient safety. I thank ASA leaderships, the ISA leaderships, as well as all our audience who have been the testimony to this wonderful webinar. It's a good beginning, and hope that, as Dr. Naveen Mehta sir said in the beginning, that we are going to have offline meeting as well. So a wonderful beginning, and thank everyone from the bottom of my heart on behalf of our ISA National, and hope that these webinars will be a continual program of our ISA National going forward, and our leadership giving impetus to such academic endeavors. Thank you very much, and thank you all. Long live ISA, and a long live friendship of ASA and ISA.
So thank you so much, Dr. Bajwa, for proposing the vote of thanks. And on behalf of every Indian anesthesiologist, we extend our sincere gratitude to the President of American Society of Anesthesiologists, Dr. Patrick Yam, for being a part of this session in spite of his very busy schedule. And I thank the speaker of the day, Dr. Jiang Peng Huang, for his phenomenal contributions, because we see he's doing excellent work on innovation and AI, and Dr. Murli for those insightful words, which are words of true wisdom. And thank you, Sarah Braun. We truly appreciate your efforts in making this a possibility by bridging ASA and ISA, and this bridge will grow stronger, mightier in the years to come. Thank you so much, and happy day for everyone. And we look forward to meeting again. Thank you.
Thank you.
Thank you very much.
Thank you. Thank you so much.
See you all very
Thank
soon.
you.
Bye-bye.
Thank you.
Thank you.
Thank you.
See you
Bye,
soon
Dr.
again
Bhatt.
in November in a national conference, which is going to be held in Trivandrum.